Good afternoon. Thank you for being here. We will get started. I'd say there is are these couple seats, are these being saved up here? No? So if you went in the back, it looks like maybe there's a seat up front. This is great that we've got such a robust audience. I want to thank you for joining us for our program today, Computational Justice, How Artificial Intelligence and Digital Phenotyping Can Advance Social Good. My name is Francis Shen. I'm a law professor who studies the intersection of neuroscience, AI, and law, and I also am here today as executive director of the Massachusetts General Hospital Center for Law, Brain, and Behavior. And I want to recognize our co-founders and co-directors, Dr. Judith Ethersheim, forensic psychiatrist, and Dr. Bruce Price, neurologist. Judge Nancy Gertner, our faculty here, can't be here, but is also a key part of our project. I'll say more about the center in just a moment. I do want to note that, and I'll say this at the end, for those friends and colleagues who can't be here, but you want to tell them about it, the program is being recorded and will be available for review later. This program is part of a really foundational and fantastic partnership that we have with the project, this project on law and applied neuroscience, in partnership with our good friends at the Harvard Law School Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics. And before we begin, I do want to give a special thanks to our colleagues there, Professor Glenn Cohen, Executive Director Carmel Shakar. Thank you to Caitlin Dowling, who is here, and of course, there she is, Dr. Christy Hutchison, for as always making these programs come alive. Thank you as well to our advisory board for the Center for Law, Brain, and Behavior that makes this possible, gives us the capacity to do it. So let me say a few words about the center, and then I'll say a few words about this program, and then we will get to it. The Center for Law, Brain, and Behavior is based at Mass General Hospital. It has faculty in partnership with Harvard Medical School, Harvard Law School, and other schools in the area. We work at the vanguard of applied neuroscience, making neuroscience actionable for the legal community in order to ensure just and positive outcomes. And our view is that though the law and the brain and certainly the technology that you're going to hear about today are quite complex, our mission is quite simple: helping judges and lawyers and other actors in the legal system improve their aims, improve the justice they bring by offering the right solutions for the right people and cases. And critical to this is being aware of and engaging with new technology. Although we are not the Center for Law, Deep Phenotyping, AI, and Behavior, neuroscience, by its nature as a discipline, is a discipline that is increasingly integrated with artificial intelligence, with deep phenotyping, and it's incumbent upon us and for this dialogue to engage as we will today. Before introducing our panelists, let me just say a few words of context about why this program we think is of interest. I mentioned there's our center. You can go to our center website, clbb.mgh.harvard.edu. Wearing my professor hat for a moment, I direct a lab. Our motto is every story is a brain story, and increasingly those stories are understood and improved with AI and with new methods such as deep phenotyping. If you don't think that the time is right for a law and AI conversation, let me give you just one data point to convince you. With a former student, Brendan Johnson, we are writing a paper called Teaching Law and Artificial Intelligence, and this is part of the graph of the data. These are law review articles referencing artificial intelligence. Law took a long time to figure it out. There was actually a lot of AI conversation going on in other fields, but law came around about 4 or 5 years ago, really, and we are seeing a skyrocketing interest in law and AI. And I teach a course in law and artificial intelligence, and there are two observations that I'd like to offer with you which really motivated my interest and our center's interest, I think, in pulling together this panel. The first observation is that a lot of the development of technology doesn't seem to account for marginalized populations. That is, if you think about your typical Silicon Valley developer walking around trying to solve a problem, the problems that come to them are, I can't get the mattress in time, or these taxis really suck, let me create a new system, or I want to find a new way to meet my loved one, so I'm going to create the 12th dating app. And yet there are so many opportunities in the world that we operate in law and in justice for those from the marginalized populations, for those suffering from deep psychiatric disorders. Is there a way that technology can be developed for those social goods? And you're going to hear about that. The second observation is that much and appropriately of the discussion in articles captured sort of in this graph are about the concerns about AI. And you've heard them. They range from killer robots are going to take over to us, to everything we care about privacy is going to be given away, and many others. And these are important concerns. And indeed, I want to credit Dr. Baker for collaborating on an ethical, legal, and social implication study around his work. And we need to think about the ethics. But as much as we need to be prepared for the doomsday scenarios, we ought to be proactively thinking about designing for the social good, designing for social justice, designing for outcomes, especially if we think for marginalized communities. And again, you're going to hear about that today. So we take a spin on law and AI and neuroscience that is, in one sense, in keeping with this trend, but in another sense, I think is very new, given the new outlook that we'll offer. Last point of context. It won't take long for you to notice that our panel is young. These are emerging stars. This is the future of some of these fields. You're getting to see a glimpse of, I think, really not just the future of the field, but the future of the superstars who are going to shape it. And let me now introduce both of them to you. So our first speaker will be Rediet Abebe. She is a junior fellow at the Harvard Society of Fellows. She is about to finish a computer science PhD at Cornell University, where she's advised by John Kleinberg. She has many other degrees, graduating as an undergrad here at Harvard in math, 2 separate master's degrees in math, one from Harvard, another from Cambridge, and works broadly in the fields of algorithms and AI with a special focus on equity, justice, and social good concerns, and examines how these developments in conjunction with insights from the social sciences can be leveraged to improve access to opportunity, especially for historically disadvantaged communities. She's not just a scientist, she is an activist. She has co-founded and co-organized the Mechanism Design for Social Good, which is an interdisciplinary, multi-institutional research initiative. She has also co-founded and serves on the board of directors for Black in AI, a nonprofit organization working to improve diversity in the field of AI. Wonderful talent, and we'll hear about her work in just a minute. Our second speaker is Dr. Justin Baker, who has a background both in neuroscience and clinical psychiatry, holds an MD and a PhD from Washington University, and at McLean Hospital, he is the scientific director for the Institute of Technology and Psychiatry and director of functional neuroimaging and bioinformatics in the schizophrenia and bipolar disorder research program. At Harvard Medical School, he is also an assistant professor of psychiatry. And as you'll hear about, his work uses large-scale studies and deep phenotyping approaches to understand the nature and underlying biology of mental illnesses, particularly illnesses such as schizophrenia and bipolar disorder. The goal is to develop more effective strategies to monitor the course of the illness and intervene in new and creative ways to improve the lives of those struggling with these conditions. So we have got a lot of great material to cover. The way we'll proceed is we'll hear first from Rediet, then from Justin, then we'll move there. I'll lead off. I've got some comments and some questions, and then we will open it up to your questions. So think, take your notes, and be ready to be engaged, both over the course of these next few minutes and beyond. We hope the dialogue continues. With that, let me turn it over to Rediet Abebe. So I'm going to let you come up and pick it up.
Actually, I don't got it. Thank you. Oh, yeah, that part. Thank you so much. This is good. Good. Hi, how's everyone doing today? Good. Good. All right. It's really great to be here. I don't believe I've ever talked to a group of law school folks. I think my involvement in this building extends as far as getting my meals here. So I'm not exactly sure what to expect. I'll say that even though the remarks are going to be, I think, only 20 minutes, I'll still allow for questions. So if something seems unclear to you or you have thoughts, feel free to raise your hand and we can make time for that as well. So as Franza said, by training, I'm a researcher in computer science. So I spend a lot of my time doing both sort of theoretical computer science and thinking about applications of AI, and I'm specifically interested in how algorithms can help reduce inequality along with insights from other disciplines. So one thing we know is that poverty and inequality impacts communities around the world, including here in the United States. And this is something that a lot of different disciplines have thought about for a very long time, and something that computer scientists have recently started to engage with in a variety of different ways. So this is something that I think about a lot in my research. I think about the sort of multidimensional nature of poverty and economic hardship, but also other forms of hardship that we'll discuss more generally. But specifically, I'm interested in sort of data inequalities, right? So communities of individuals that are already disadvantaged tend to be also disadvantaged in our data collection process. So these communities tend to be underrepresented, misrepresented, or entirely missing in our data sets, right? So it might be that we don't really have a very good sample of, let's say, communities of color. It might be that we don't have very good data about pregnant women, especially pregnant women of color. It's only in 2015 and 2016 that there was really a data set that was specifically focused on trans communities in the United States that we were able to collect and actually try to get some insights. And if you're focused on, let's say, individuals living in resource-constrained regions, right? Like, let's say, in a lot of developing regions, a lot of data is very, very hard to come by. It's not collected in a sort of systematic manner. It's not comprehensive. It's not, you can't regularly sort of rely on it. And what this does is that it basically makes it very challenging to identify where there may be sort of gaps in our policies in terms of assisting these communities, and also where there might be issues that we just haven't even thought about, right? So for focusing on, for instance, individuals living in resource-constrained regions, and let's say focusing on the African continent, we know that basic disease statistics are very hard to come by if you wanted to focus on health. So, for instance, if you wanted to know, let's say, how many people in South Africa died of AIDS last year, this is data that's very, very challenging to come by. And South Africa is actually one of the countries that's doing better in terms of data collection. So if you're looking at, say, Ethiopia, where I was born and raised, good luck, right? It's very challenging to even get very basic statistics like how many people died of disease X, right? And so certainly, more nuanced data, like what are people's health information needs, or where might there be misinformation about specific diseases, or even basic disease statistics about lesser known diseases beyond HIV and AIDS is very challenging, right? So what I think about in my research is basically, we already have some data sources that we're trying to use as best as we can, but what other unique data sources are there, and what other analyses could we do to kind of supplement and complement what we already have. So one work that I did with collaborators at Microsoft Research and Stony Brook University was to use search data to gain better insight into people's health information needs across the African continent. So we had search data from all 54 nations in Africa, and we were able to analyze this large data source and use sort of topic modeling and natural language processing to get better sense of people's health information needs. So by analyzing this data set, we were able to kind of get these topics. These are known as topics. Basically, these are clusters of words that are frequently co-occurring in search queries. And so oftentimes they kind of correspond to what we consider to be topics in a more colloquial sense. So you have, like words like drug, treatment, patients, abuse, therapy, drugs. So that seems like a drugs topic. We had topics related to symptoms, and also testing and antiretroviral drugs, but also things like breastfeeding, gender inequality, natural cures and remedies, and stigma, right? So basically, what we were able to do is we were able to analyze this very large data set to get a better sense of the kind of topics that appear, and then we were on top of that able to see, is, for instance, the stigma topic relatively more popular in Botswana than it is in Ethiopia, right? And other analyses like, among women, what topics tend to be more popular, among younger or older age groups, what topics seem to be popular. And what's very interesting about this is that, if you talk to folks working in HIV and AIDS within the African continent, they'll tell you that, getting information about people's queries related to stigma or people's questions related to natural cures and remedies is really, really difficult, right? Because, if a disease is stigmatized, it's just very challenging to actually have a conversation about that and get a sense of, let's say, if someone is HIV positive and they want to know what their legal protection is to not get fired where they are, it's really hard to have that conversation. But what you have is that in search data, you basically have those questions readily available. There are a lot of searches that were like, I'm HIV positive, can my boss fire me? And the answer is actually yes in some countries. So it's a very interesting way to get at some of these hard to survey information in a sort of responsible way. And we were also able to look at what information were people being provided once they asked these questions. We looked at the web pages that they were being shown, and we saw that there's these huge discrepancies. So basically, on the x-axis here, you have average quality of content on a scale of 1 to 5, as measured by relevance, accuracy, and objectiveness of the content of web pages that one would be able to see. And then on the y-axis, you have different topics. So the symptoms topic, natural cures, drugs, so on, that I showed you on the previous slide. And what we found was that the natural cures topic rated at about 1.5 out of 5, meaning that we had folks who had graduate level training in medicine and public health, and we showed them the content and said, how relevant, accurate, and objective does this information seem to you? And more often than not, they said that there were serious issues with objectiveness, accuracy, and relevance of the natural cures. And then, other things like stigma, breastfeeding, and drugs were actually doing better, much, much better. They were at 4 or above out of 5. So there was good quality content that was being provided online. And some things like symptoms, this was a bit of a surprise to me, actually. When you're searching for questions related to symptoms, you're often getting not so great information either, right? And this is really the first time that someone had actually looked at the quality of content that one would be able to get within the African continent, probably related to any topic, but certainly related to health, to identify these discrepancies that might exist. So what does that actually look like, right? I'm talking to you about this at at a high level, but actually concretely, what does it look like? Well, if you search for at the time that I posted this, right, if you search for does garlic cure HIV, which is a very common search query that I've seen in the data set, then you would get this web page. This is on Bing, but actually this was true on Google as well. You'd get this results page. The first website is a website called miracleofgarlic.com, and this was something that even I, with very, very little health training, could identify had a lot of ascientific information. And not only was it the first web page, actually, it was highlighted, right? It's a sort of like an answer. And this is just a sample example. You could look at this for other searches related to natural cures and remedies, and you'd be able to identify a lot of things like this webpage that you see here. But maybe that's normal. Well, let's see what you would get if you were looking at, let's say, antiretroviral therapy HIV. This looks totally different, right? So the top webpage that you see there is a webpage that was consistently rated highly by folks that I mentioned to you rated our websites, but actually the whole experience looks very different. You have on the right-hand side a Wikipedia page about management of HIV and AIDS, and then it also has, maybe it's too small so you can't quite see it, but it says, what do you want to know about this condition? And then it suggests different queries that you could search, right? So basically, if you're looking for natural cures and remedies versus medical cures and remedies for HIV, the experiences that you would see are totally different, at least as it would be rated by someone who's in medicine and public health, right? So this is one opportunity for us to first identify disparities that exist online, but also see what kinds of interventions we might want to look at and things that we want to work on from sort of the more algorithmic side of things. So this is more on health, right? What I've talked to you about so far about these disparities and inequalities that exist, how we might be contributing to them, is on health. The results that I mentioned to you are in this paper called Using Search Queries to Understand Health Information Needs in Africa. I gave you a very small sample of results that we have. There's a lot of really interesting things in there. I encourage you to look at it if you're interested. And so this is related to health, right? But I like this table that you would find in like the first few pages of a book by David Grusky called Social Stratification. The sociologists in the room probably recognize this book. So this is the book that we used when I took the graduate inequality class in our sociology department. And in the first few pages, you see this table that says, examples of advantaged and disadvantaged groups, and it shows you these different basically dimensions, right? So if you're looking at physical, right, at the bottom it says, mortality, physical disease, mental health. These are different variables and dimensions of physical advantage or disadvantage. But you can look at other parts of this table as well. So you could look at, let's say, economic, right? So you could have wealth, you could have income, ownership, and these are just examples, right? So basically, what I learned in that class and what this table is saying is that disadvantage, we tend to talk about as this very one-dimensional thing, but it's actually very multidimensional. So if you're talking about poverty and economic hardship, you could have income, wealth, but then a bunch of other things also that social scientists have long recognized as being as contributing into economic disadvantage. But there's a bit of a disconnect here, right? There's the social science work that recognizes that, but oftentimes the tools and techniques that you would be able to use within the social sciences may not necessarily lend themselves into kind of getting these large dimensional spaces, large dimensional complex dynamic spaces, and actually getting something tractable, right, that you can reduce and be able to use. But the good part of that news is that actually, as a result of not this inability to maybe reduce these large dimensional spaces, a lot of interventions that you would have, like the Supplemental Nutrition Assistance Program or any of the low-income housing assistance programs, Medicaid, and so on, they often tend to use very one-dimensional things. They'll just say, are you above or below this income threshold, or what percentage of your income do you use on housing, and things like that, right? So they tend to use very one-dimensional things with the recognition that actually economic disadvantage is very complex and multidimensional. But the good news here is that in computer science, right, which is the field that I'm in, we love large, complex, multidimensional spaces. And maybe there's an opportunity here for us to also contribute some things, some insights that you would be able to get by kind of leveraging the techniques that we've developed for different means towards understanding these multidimensional spaces of economic disadvantage. So to that end, Francis had briefly mentioned this initiative, the Mechanism Design for Social Good research initiative that started actually as a very small reading group 3 years ago. It was started by myself and Kira Goldner, who's now at Columbia University. And what we wanted to do was basically we saw that there were these kind of disconnects that existed, at least between computer scientists and other disciplines that were adjacent to us. And so we wanted to just learn, right? We wanted to read law papers, we wanted to read economics and sociology and public policy papers, and see where we could kind of identify questions where there's opportunities to do multidisciplinary work. And since then, this reading group has grown. It's a large initiative now. There's about 500 people that are involved in some form, but many other people many of those that are involved in many more active ways. So we have a colloquium series, working group series, a research group that we started with, workshop series. So for the colloquium series, we have these monthly online colloquium series. I should mention that a lot of our activities happen online because we're all scattered across the world and across the United States. So this colloquium series, we've been able to highlight work that we've been very inspired by. So the first person that you see there is Professor Al Roth, who was actually in the economics department here at Harvard for a while. He was able to get a Nobel Prize due to his work on school choice mechanisms and kidney exchange, and he was very generous to share his time with us and kind of tell us best practices and things that he learned from the many decades of work that he did bridging economics research and practice. We've also had Professor Tawana Dillahunt, who's a computer scientist and information scientist at the University of Michigan, and she does really remarkable work on designing technology for disadvantaged communities. So if you had low-resource job seekers, how would you change LinkedIn, right? What would that even actually look like? And so she does really incredible work there, and she was able to share a lot of the work that she's done in Michigan, where she's based, with us. And we have several others that are coming up this fall. So there's one actually on Friday by Kentaro Toyama, who's one of the founders of the Information Communication Technology for Development Research Community. So you'll be sharing his insights with us from having founded this research community, I think maybe 15 years ago or something. We also have Pauline Kim in I believe, November 14th or 15th, whichever is the Friday of that week. So she's a lawyer or maybe a law professor at Washington University in St. Louis. So she will be talking about, I think her talk is called Manipulating Opportunity, and I think she's focused on online platforms specifically. And we also have a third one by Lisa Salis, who's a statistician at Yale University. Not sure what she's going to be talking about, but her work is fantastic. So I'm sure it will be great. And in addition to these online colloquium series, we have these working groups basically that have been meeting bi-weekly online to really do domain-specific work, right? So if you were interested in, let's say, housing issues, so we had this working group that was comprised of researchers from many different disciplines and also some folks who are not researchers to identify opportunities for improving, housing, access to housing for disadvantaged communities. And we have a bunch of other working groups as well that have been doing really great work. So if you're interested, you can go on the website, take a look at some of the short descriptions that they've provided and see whether this seems interesting to you. And we've also had, once a year we get together physically. It's really great. And we started it as a workshop series back in summer of 2017. It was at MIT. It was the first workshop on mechanism design for social good. We've had our second and third workshop in 2018 and 2019, respectively. And this summer, we're considering exactly what we want the community to look like and grow it beyond a workshop so that we can kind of facilitate more than just a one-day discussion, but maybe a multi-day discussion. So if you check out the website, you'll be able to kind of follow along with what ends up happening there. And these are the wonderful folks of MD4SG and some of the research that I mentioned that I've been able to work with. And thank you.
Transition in here from Dr. Baker.
All right. Well, thank you so much. Fascinating discussion. Again, my name is Justin Baker. I'm a psychiatrist and a neuroscientist. And the work I'd like to tell you about today is some of the work that my lab has been doing over the past decade or so to really rethink how we're evaluating people with conditions like schizophrenia and bipolar disorder, and really kind of going way deeper into how we think about behavior beyond the DSM and diagnostic labels to really kind of capturing what it's like to experience these illnesses. Originally to kind of do better biology, but I think as I'd like to give you the impression today is that in creating systems to study biology more effectively, we're starting to find ways, I think, of potentially developing systems that could be that illness vigilance system for a condition like these severe mental illnesses. But I think as hopefully we'll get into today, this raises all sorts of interesting and complex ethical issues about disease surveillance, both for people who've already opted into care, but also for people who may be at risk. And so, one of the things we try and do with all of the work is to not just identify people who may have a need, but to really ultimately design tools that meet people where they are and meet the specific needs that they may have. And so this is just to kind of emphasize some of what you were hearing in the previous presentation about really trying to use design-centered thinking to kind of figure out how to actually solve real-world problems, not just the problems that doctors and legal analysts might decide is a problem, but a problem for the actual individual. And for us, and for my lab in particular, this has always come as this question of how do we ultimately link what we're seeing syndromically in terms of people who might present to us in a clinic or a hospital setting. How do we ultimately link that back to variation that we're seeing in the brain and in the biology? So whether that's genetic variation all the way through variation at the level of brain structure and function, which was the main thing that my lab has been studying, all the way up to sort of the actual objective signs that can come along with symptoms of these conditions. As you can imagine, this is a very complex way of sort of mapping different levels of variation to try to understand the system better. And what I like to sort of use as a framework, partly because we've just heard from a computer scientist, is this idea of latent construct models. And so this is something that's very familiar to engineers. Control systems are really built around the idea that you can take in data from the environment, some kind of sensors, do some sort of key extraction of just the key features from those raw data, Ultimately, the goal, though, is to inform some sort of construct model of a latent variable, something you don't actually have the ability to measure directly, either because of some pragmatic issue, like it's just hard to measure things in a certain setting, or that it's a latent kind of conceptual model. So like, let's say guilt and innocence, right? You don't know in a courtroom whether someone actually is guilty or innocent, but it's something that the system is designed to extract from the available evidence. And I think that there's another key here, which is sort of the second part of this, which is that in any good latent construct model, you're not just trying to feature engineer the truth, you're actually trying to iterate that, right? So you use motors and actuators in the sense of a control system. You interact with that system ultimately to provide feedback on your model, and then thereby sort of improve over time the ability of your model to be consistent with the available evidence. And so I think this is a concept that is really kind of should resonate with most of you, probably regardless of your background. For me as a neuroscientist, this is really kind of just how the brain works, right? There's a lot of sensory systems, each designed to pull in different kinds of raw data from the environment, but we've evolved a very complex brain to do just the key feature extraction that we need from those raw data, ultimately to kind of compute things about the world that we need to survive. But then we actually use movements to interact with that world and generate our own feedback so that our predictions over time as we develop, get better and better. It's also something that we're constantly contending with as clinicians, right? And maybe, again, in a legal context, this would also be true. You don't know the mental state of the person behind. You don't necessarily know what condition they have, but you have your well-honed sensors of listening and observing, and we use those and try to use our training to pull out just the key features from our patients that allow us to inform these models. And then a good, like Dr. Price, a very good neurologist or psychiatrist can then use specific probes, questions, actual actions to generate feedback, additional information that was maybe not presented initially, to gradually hypothesis test and refine those models. And so the work that I'll talk about today, where we're starting to use these devices, is really no different, right? It's just trying to put sensors into the environment of people who have these illnesses, and then through the same kind of process of iterative development, try to understand what are the latent states, what are the states that somebody's in when they're by themselves at home in their natural environment, or even in a clinic where maybe someone who has a variable ability to do an interview is interviewing that person. How do we use devices that you can actually just purchase? Many of you probably have some of these devices with you right now. So this is not talking about the really expensive devices like MRI scanners. This is really about how can we begin to capitalize on commonly available technology to essentially begin to understand human behavior in the wild. And so for us, this is a complex issue because, if you're studying this from a biological standpoint or you're trying to do clinical evaluations, it's not the simple case that you have your patients and you have your healthy people, and it's just about kind of separating the two groups. Hopefully everyone in this room can appreciate that the idea of a patient and a control is sort of an outdated concept. Now we kind of recognize that not only are there many types of caseness, you can have many different conditions, illnesses. There's maybe continua where there's people who are healthy all the way up to having conditions. But also that even at the individual level, there's a sort of chimeric quality of people can have multiple types of illnesses at the same time, potentially. And how do we account for that heterogeneity, whether we're doing a large-scale genome-wide study like the Human Genome Project? Those kinds of projects are going to have limited social impact if they can't account for the behavioral heterogeneity that we're seeing. I think that's one of the reasons that despite the progress that we've seen in genetics and neuroscience, a lot of these findings are not making it into clinical practice, especially not in psychiatry, where we still rely for the most part on kind of the just regular interaction with humans. And so, just to kind of visualize this, we took about 1,000 individuals who had come in for one of our studies, and what I'm showing you here is positioning everybody in the study. Each person is represented by a single dot, and they're separated from each other based on how similar they were looking symptomatically when they were being evaluated. So everybody here I'm showing has a diagnosis of schizophrenia, so they've gotten that same label, but as you can see, they're sort of spread out. They have a lot of different presentations. And now if I just superimpose everyone who has a diagnosis of bipolar disorder, you can see that although there might be a little bit of difference there, it's a very murky cloud, right? People who have these kind of core disorder labels can often look very, very similar to one another. I can add in other disorder types like schizoaffective disorder, which is sort of some would say kind of a grab bag diagnosis. And in fact, we see that people with that label have, symptoms all over the map. And you can kind of keep showing that these labels that we use routinely and have kind of all sorts of treatment implications, they don't really help us to distinguish people in any kind of meaningful way. And so confronting this, we were really faced with this problem of how do we get past these kinds of evaluations, which are really based on a single point in time where you have an interview with somebody. And that raises the other issue. These syndromes are very complicated over time. They're dynamic. People can go from well to ill, back to well in a span of days. And so how do we actually begin to account for that kind of heterogeneity where that just adds another dimension to these kinds of problems? And so the way we had been doing it with just kind of human resources, having someone sit in front of another person and ask them a bunch of questions, it's just extremely time-consuming and human resource intensive, very costly to the system, right? It's one of the main drivers of cost for the healthcare system is having to have enough people who are trained to do these kind of evaluations and extract those raw data, because without the human feature engineering person, right, there's no way to do these things at scale without tremendous cost. And this is true for research, where we train our research assistants for weeks and months to perform these evaluations. But it's equally true, maybe more so for physicians. You train them, think about how many dollars goes into training a single psychiatrist. It's quite staggering, right? And yet, for some basic kind of data integrity issues, like these are not good measures, right? They don't have the kinds of intertemporal, inter-rater reliability that you would expect from any other sort of data you were collecting in the environment. And so for us, this caused me to sort of take a step back and begin trying to find collaborators in computer science who could help us do some really simple things. First of all, it was just turning a camera on and recording some of these evaluations we've been getting. But then rather than kind of getting buried in the, the staggering amount of data that you then have to watch all these videos and somehow make sense, we can take advantage of the fact that the machine vision world is quite mature, and you can extract all sorts of meaningful features from raw video of people. So over the past few years, we've been collaborating with the Carnegie Mellon Group to collect dyadic encounter data, so people who are hospitalized for severe mental illness, and they basically, over the course of a hospitalization, will undergo these evaluations where really we're just asking them the 10 or so questions that we would ask on a typical morning of clinical rounds. So, spend 5 minutes with somebody to get all the kind of key features you need to make billing decisions, to change their treatments and potentially their lives, right? That's happening in the span of 5 minutes. So we thought, why not just try to extract exactly what the clinicians are extracting? So what I'm showing here is these sort of 12 or so questions where we have both the participant who's a patient, the evaluator who's a trained psychiatrist, and then on the axis here is this 10 or so minute encounter. And then each row of this plot is showing you a different component of their facial action unit. So the different parts of their face as they move. So the top row here is like if you're raising your brow. The second row here is if you're furrowing your brow. And these are not saying whether you're happy or sad. These are just showing, how is your face moving as you're encountering this common clinical encounter. And so you can see that we intentionally leave the participant alone for the first 2 minutes of the encounter because that's actually a time when often there's really interesting pathology that you can see if you're kind of taking a look at them without being observed. And so you can see this person is kind of raising their brow, looking around the room perhaps. The moment that the clinician enters the room, you get a strong response of the smile. And then over the course of the interview, you can sort of see as this person is answering the questions and having different kind of facial gestures as part of that natural conversation. And you can also see in this case that the clinician is captured as part of this. So we can see, this is somebody who's well trained. How do they move? What's their what's their method? How do they kind of use their motor system to kind of optimally pull out these signals? So you can see, for instance, this clinician does not smile, right? This clinician does a lot of brow raising, squinting is common, right? But it's for the first time, sort of like almost like an EEG of behavior where, you can begin to get some intuition about looking at these things and seeing, let's compare a trainee as they get better and better. Do they smile less and less? Do they, show certain patterns? Does that correlate with how that patient goes on to do, or any kind of label that we might assign to them later? So just to kind of highlight that this is now not just possible, but really actually quite technically easy. You just throw a camera in the room. We've been asked, a lot of the concerns people had of like, well, would people do this? People willing to be filmed? Like, yeah, nobody really seems to mind a lot of those kind of things that we had feared would be issues, right? And some of it is like, well, these are vulnerable populations. How can you, do this with somebody who's paranoid? It's like, they are. I mean, these are research studies, so they're allowed to opt in. We're not doing this as part of standard care yet, but our experience so far is that, patients and doctors are actually quite interested in this and don't find the privacy and filming issues too concerning. Also say that, people get very used to the presence of these recording devices almost instantly. So you might think, well, how, doesn't it change the experiment when there's a camera in the room? It does change it, and people who are manic will often look at the camera, and maybe be preoccupied sometimes. But we see that as an advantage, really, that the camera's in the same place for everybody, and so to the extent that it varies as a function of illness, or even more, I think, to the point, is within the same person as a function of their own illness, it's, I think, still a really useful measure. So, you can begin to do all sorts of, math to show that these measures actually correlate with things that might be useful. So you can take aspects of their brow furrowing or their brow raising and actually use them to predict some of the conventional measures that we would get in a clinical trial, let's say. Here, for instance, the amount of brow furrowing doesn't change as a function of depression, but how much the variance in your brow furrowing goes down the more depressed you are, which is sort of consistent if you think of people who get really depressed just have very little expressivity at all. And I think that we see evidence for that here. Also, as I mentioned, in that alone period, we see people who are more likely to later be assigned a high unusual thought content, right? So more psychosis, are doing all sorts of social gestures during that alone period that we just don't tend to see in most people. So, again, we can try, just with very short amounts of time and small samples, we can get pretty reasonable correlations of these measures with standardized measures. And then I'll just mention quickly voice. So voice is another thing that I think is a really interesting type of measure because it's something which is not as hard to capture maybe even as video. But something as simple as your vowel space. So this is sort of how different do your vowels sound from one another. If you think of like your pure ah, e, and o, there's like a normal space in this kind of high dimensional space that would take up. And it turns out that people who are depressed have much lower vowel spaces. So it's again that kind of constriction of their expressivity perhaps. And we also found the converse, that people who are psychotic and manic tend to have this kind of hyper articulation and like separation of their vowels that was sort of this converse of what we see in depression. And again, this is more just proof of concept at this point, but what we're showing is that, the idea is that you can take measures like this. So here's a cloud of all of the conventional measures that we were collecting from one of our studies. So, the different colors just show different, the PANS is a positive and negative syndrome scale of sort of psychosis symptoms. The MADRS is it's like a depression rating scale, and the BPRS is a commonly used scale of function. And so these are all of the different items that you would spend hours to evaluate to get sort of a full picture of someone's pathology. And so with the new measures, we can sort of essentially drop them into this and begin to using the measures we can acquire automatically to predict what we would be seeing in the conventional measures. And I think over time, again, this is just tip of the iceberg. As we acquire more of this data, it's really just a matter of like having enough data to do these mappings more effectively. And we're going to be able to, with increasing precision, be able to estimate how someone would score, even on something as complex as sort of, are you having delusions or are you experiencing something that you might not be willing to share with us? And it's the last few minutes, I want to mention another line of work that my lab is doing is to try to take this sort of approach of really getting some hard objective measures and now extending this over time as much as possible. So we've been following a cohort of about 30-odd people over the past 3 years or so, where we capture as many of these sort of high-dimensional measures as possible, and we try to do it in a way that's as low burden to those individuals as we can. So this is a study, and this is why we call it deep phenotyping, because you're sort of going really deep and collecting lots and lots of data types, different sources of data, to capture the most rich kind of clinical picture you can from someone. To really ask the question of, if you have one of these conditions like schizophrenia or bipolar disorder, we have sort of our assumptions about, well, okay, that means you're manic and depressive and you have this kind of life, but in reality, what does that actually look like? How do we distinguish, how do we really, at a bird's eye view, begin to capture what it's actually like to have these conditions? And so what we're doing is following people where we can get multiple study visits, so the kind of same visits we were doing before, but doing them over time and getting pictures of their brain at every few weeks over the course of a year, getting those interviews so we can get those kind of conventional measures, but with all of the video data and audio data to go along with that. And then we give them, well, actually we don't give them, we just let them use their own phone to collect a lot of the other data. So there's an app that we're using that allows us to collect daily questionnaires from them about how they're doing. They can record a short audio diary about each day, just what are they experiencing and kind of what's going on with them. We also can look at things like their location, how their location changes as a function of maybe their illness. Here's an example of someone who was living at home and then right in the middle of our study moved back into the dorm after having multiple hospitalizations and manic episodes. This is a key moment for us where someone is trying to get well again. They're at risk. They really don't want to go to the doctor or think about that bipolar disorder, but there's certainly a huge risk. And so how do you design systems that could monitor somebody, when they're opting into care, right? They're taking some medications, but they probably don't want to think about it at all. They probably never want to go to the doctor. So how do you design a system for somebody like that who may, and this person actually did end up having another manic episode down the line? And this, by the way, is just showing the distance that person is from their home at any moment. So the redder color is showing that they're kind of moving away from home. We can also look at actigraphy from their phone, just how that phone is moving around in the world. We can also look at calls and texts, although we don't, in our study, look at the content of calls and texts. We can see how many calls and texts you're sending. We can also get sort of a rough picture of your social network and sort of which numbers are you hearing most from. Are you responding to those numbers? Are you ignoring certain calls? And we also have a separate device that we have on people to get risk data. So that's a device that we do give to them. And so even though there are places where the individual might turn off their phone or uninstall an app, we have this other kind of continuous measure of activity that we can use to capture sleep and other things like that. And so just one example that I'll show is the power of what location itself can tell you about someone's life, which is both, I think, really revealing, but also, starts to border into the creepy or the ethically, how are we going to use this? So here I'm showing you a couple of years' worth of significant locations, which my postdoc Habib's audience has created. So this is just looking at where someone goes on the basis of their phone over the course of this period. Here you're seeing time of day, so just going from morning till night, where noon is right in the middle there. The gray location is that person's home location. And then over the course of this period of time, you can see that there's a number of different colors that pop in. So these are just locations that for that individual were common. And then you can see locations like this blue location here, which, each of these, I should mention, each of these columns here is a single day. So those blue locations are places where, he doesn't live, but over these two particular periods, he's going there for 7 to 10 days or so. Anyone want to hazard a guess of what that location might be? I'll also mention that it's a place that you'll also see throughout the record as a place that he goes quite a few times during the day as well as in the evening. So.
What's the diagnosis?
Well, this is bipolar disorder. For 10 days straight? So he does have an issue with alcohol, and actually in the first of these, he was drinking a lot, and then he got manic, and then he ended up in the hospital. So those blue locations is the hospital. So you can see very clearly there's no inference, and there's not a lot of, it's still a latent construct, right? We don't know he's in the hospital, but in this case with GPS, we can be pretty darn sure, he was in the hospital for those 10 days. And then you can quickly begin to see, all right, well, was he missing any appointments right before the hospitalization? Was he showing up? These later blue locations are his AA meeting. So did he just stop going to AA for a couple of days and that maybe precipitated the episode? You can see he got hospitalized twice here and then has a period here where this teal location is a part-time job that he has. So you can quickly see, how's this guy doing in his social community functioning? Is he making it to his job? You can see that after that second hospitalization, that teal location goes away. There's no part-time job for a while here. And then at some point later on, he picks up another part-time job. And then there's this orange location that shows up. So that's a location that he starts to spend the night at a bunch of times. Anyone want to guess what that location could be? It is indeed a new friend. So this is somebody who he meets. It's kind of hard to pinpoint the exact moment, but you can see an orange location kind of come in here some evenings. And then at some point, he develops a romantic relationship with that person and starts sleeping at that person's house with some regularity. You can also see it kind of fizzle out around here. And this is something that, is part of a young man's, life of really, like, he doesn't think of his life as trying to avoid the bipolar disorder. He thinks about it as, how do I get my job and my relationship going, right?
Do you monitor medication compliance?
Yeah, great question. So we have them as image. Oh, yeah, sure. Oh, sure. So the question was whether we monitor medication compliance. So in this study, we're not taking care of these folks. So we don't, although we do pull from the electronic record. So we can see how his medication doses have changed, right? And then when he comes in for his monthly visits, we ask him these kinds of questions all the time. So just as a quick anecdote on this particular guy, I saw him just last week, actually. He had been well. He mentioned he now has a full-time job, and he decided that he didn't want to take his Seroquel anymore. He decided, it's over sedating, I'm going to stop taking it. When he came in, though, he was definitely hypomanic, and he had also said that just 2 days before he had stayed up a lot and was definitely borderline manic, and then he drank a lot and slept a lot, and he somehow dodged this bullet, which in my sense, he hadn't yet dodged because he still was not taking his Seroquel dose, and he hadn't told the psychiatrist this, and he was getting more manic. So we don't have full control over that, but they do, we ask them these questions regularly, and I think oftentimes, when we detect there's been changes, we'll especially want to probe. I always ask at each of my visits with them about medication changes. So, yeah.
Another medication question on physical measures like facial muscle movement.
Yeah.
The type of medication and the dosage, do you take that into account? Or how can you do that?
Right. Well, so I guess I would say that we think of this mostly as looking at within subject over time. So in other words,
Not the same medication.
well, even with changes in the meds. So in other words, so there can be changes in multiple meds, and I think there's, we try again to get their EHR, their electronic health record data where we can, but we're not for this study trying to restrict for just people we take care of, so it can be challenging. So you can divide these kinds of data up now that you have them into different sort of, look at the different ways. So just seeing how this person's daily, day-to-day within the week patterns have changed, you can really quickly begin to pick up on these transition points where something, really abruptly changed in that person's life. You can zoom right into, this is all the Sundays that he was in the study for quite some time. And then even something as small as these little red locations. So these are locations that you'll see sort of scattered throughout his record. They're always right before he goes to those locations, he's in the gray location, which is home. And then right after the location, he goes back to his home. And they're kind of all over the place, sometimes even multiple times in the span of a couple of hours. Any guess on what that location might be? Yeah, good ideas. Liquor store, shops. So this is, so turns out this location is where he goes to smoke a cigarette. And so this is a guy who we know is a smoker, and he smokes more when he's more anxious. But it's the very fact that we know that he's going to a location that's near his house, but it's not in his house. And we know from, again, sort of the extensive interviews with him that, he smokes and he goes near his house to smoke. So using that much information, we can then begin to zoom way into those individual moments when he's where he usually goes to smoke, and do things like look at what his actigraphy watch is doing to see, like, literally how many times he's taking a drag on his cigarette at the time he's at his typical smoking location, and get just a very detailed, granular view of what behaviors he's engaged in. And we were talking about topic modeling earlier, where you look at word clouds. Imagine the sort of list of topics of what behaviors you do when you're at different locations, and it's a pretty finite list, right? And as those behaviors change, if you're looking as a function of where you are, you can get a very clear sense pretty quickly about what kind of behavior this probably is, and whether it's part of someone's usual routine of behaviors or whether it's some sort of deviation. And I think, just again, zooming way out, this is 7 individuals in our study where, just knowing what I've told you so far about that gray location being the home location, you can look at these kinds of maps and get a really different feel for what kinds of lives these individuals lead, and maybe where there were significant transitions for each of them, without even knowing that much more about them. I can tell you that these are all people who have some kind of condition, but some of the transitions you see are normal, like going back to college. Some of them may be related to illness, but we really see these methods as ways to really, in a low burden way for the individual, to be able to capture things like, what is their social community functioning like? In a way that maybe is less sensitive to the cultural details, because even if you were to take this into places where there aren't the same kinds of services, location is something that is quintessentially human, and we can measure that with a phone virtually anywhere on Earth. So I think where we're seeing this as, there's quite a bit of potential to combine these methods, and this is just sort of like our high-level vision of how we can use these comprehensive kind of computational phenotyping approaches, which are ultimately about extracting these latent features from what raw data we're able to collect, but ultimately to feed those kinds of information into algorithms, and whether it's to use it to improve systems of care or billing, or provide tools directly back to that individual who's having issues, or their family member, or their peer, or their doctor, and really kind of rethink what would be an ideal system for having disease surveillance in mental health, which I think for us we see as this huge unmet need, right? There's as anti-stigma campaigns reduce the barrier in some cases to acknowledging issues with mental health, we have nothing to do about that, right? We don't have the treaters, let alone Africa. Even in Cambridge or Boston, good luck finding a treater quickly. So I think we're having to really reevaluate just a lot of our assumptions about what it means to get quality care, and I think this extends this discussion into sort of how do we design systems that are also going to be better at prevention, right? Because I think if you can intervene early, all the evidence would say we can reduce some of the morbidity, mortality. So that gets into some thorny ethical questions about how do you decide when and where to use these technologies in actual practice. And so with that, I think I was just going to end by mentioning that I get asked a lot, like, will AIs eventually replace psychiatrists? And we actually have a debate coming out relatively soon in British Journal of Psychiatry. And I think it's an interesting question, and I think what I hope to have convinced you is that there's a lot of really useful things that these technologies can do to reduce the burden on human psychiatrists. My take is probably that when you're in distress, you probably still want to interact with a human and not a computer. Maybe that'll eventually change, but I think, as we say in medicine, we shouldn't be afraid of automation because there's so many things that a doctor really can't do, and if we can automate it, we should probably think about ways to automate it, and there's still probably plenty left for the humans. And then I'll end with just this one quote from a patient who was actually in one of our bipolar disorder symposia, and as we think about designing for real people who want to drive their car as fast as they can down Route 1, in California, and really navigate risk in a way that's, going to change throughout their lifespan. The goal of any, ideal system is not to just squash all risk. If you try to do that, you're not going to get anyone willing to engage in your care system. and the quote was, "We will never prevent the violent autonomy of human behavior," which I really just like that quote because it captures, I think, not just what bipolar disorder maybe is quintessential there, but just the challenge that we're up against. Is we have to design systems that work for people, meet them where they are, use data, but use it in ways that I think today's technology and software can do. I think we're technically able to do it, but I think culturally we're still trying to get our heads around how do we optimize the use of these data so that they help us and not just marketing companies and things like that. So thanks a lot.
Thank you. That was great. So what we'll do is have a little bit of discussion. We've got a good amount of time, and I'm going to start off with a couple of questions that I had, and you've sort of prepped you for both of these. So one of the reasons that we love to bring non-lawyers into the law school are the fresh perspectives that you bring to help us think through our intractable problems. And Rediet, I'd like to start with you. I was struck that in designing the mechanism for social good, you're really reaching out into a lot of areas, and
Right.
one that would seem to be a natural addition would be law.
Right.
We have any number of sort of analogous issues in terms of inequity, of resources, of access, of
Right.
information.
Right.
So I was just wondering, and I'm sure maybe some of you have specific instances in mind, what would it mean to sort of develop, and using your terminology, a working group on
Yeah.
social design for law? How does that go about? How do you get the right stakeholders there? In particular, related is there's certain knowledge that only you and your colleagues have because of all your advanced knowledge. Yet how do you include stakeholders?
And vice versa, right?
Yeah. So
Yeah.
how does that? What would that look like? If
Yeah.
someone after this got inspired and said
Yeah.
they want to sign up and they want to do it with law, what would that look like?
So I should confess that I had a little bit of a preview into that question. So that's why I have my computer up here. So what we've done is actually, so for the last workshop, which happened in June 2019, we had it was a very small track, but we had a law and policy track. So we had 3 presentations in it, I believe. So there was a keynote on reducing greenhouse gas emission and mechanisms for doing that. That was a little bit about law, maybe not quite as much. So there was that keynote that we had. And then we had 2 presentations that I was really inspired by. So we had one that was on school choice mechanisms, right? So the ones that you'd have here in Boston or Cambridge, for instance, that basically assign students to public schools, right? So families would enter their preferences, and then you'd take in those preferences, and then you'd have some sort of mechanism or algorithm for assigning students to public schools. So this presentation that we had was basically covering how having information about the mechanisms themselves, having information about basically the optimal strategy, right? Because you can sort of try to game these systems in a sense, right? So having that information, how does that change behavior, right? This is a very important aspect of allocating public goods is actually, maybe I have more information about how to kind of make it work for me more so than my neighbor. So there was that presentation that was kind of related to policy. And then also we had a more law-focused, I guess, presentation that was on, now algorithms are increasingly being used in hiring, right? And we don't exactly know what the algorithms are doing because a lot of times these algorithms are developed by companies, so it's a intellectual property question, right? They're not going to just tell you exactly what the algorithm does, and they're being very widely adopted across many different sectors for making decisions at different stages in employment. So basically what this paper did was to look at what information you can get from the companies. Okay, maybe you don't have access to the algorithm, but you have their descriptions of it, about how they try to avoid bias and discrimination and all that stuff. And basically using these auxiliary information to get a sense of how bad are issues of discrimination and bias in automated employment. So there's some directions here. I mentioned these as kind of really basically starting points. I think there are probably very much deeper conversations to be had about law and mechanism design and algorithm design that I think would be very interesting to explore. So if you're interested, please reach out to me. I would be very interested to hear what you think.
A question maybe for both of you, but especially for Justin. I was thinking as you were walking through the monitoring you do that in some ways what you're describing is probation surveillance on steroids. And There is actually, many of you know, a conversation in one of our focuses in the center is on sentencing and the use of algorithms in determining predictions of future recidivism and dangerousness. And really what the system is trying to do at a rudimentary level is give a whole bunch of conditions and then actually follow up. So the classic parole officer out there and check in with your PO. I'm wondering just what you think about the use of some version of what you're doing for improving the efficacy of court-imposed behavioral interventions, which range across everything from don't use drugs to be in by 5 o'clock to take this drug, et cetera. Mm-hmm. Is that a really exciting thing, or should we really be really scared about that in the government's hands, or something in the middle?
Yeah, that's a great question. Well, so I think, in our work, we're always having to make negotiations with patients who are ambivalent about being tracked, in other words, ambivalent about being in care. And so on the one hand, they don't want to end up back in the hospital. And so they're willing to engage in a little bit of less autonomy in exchange for sort of long-term autonomy, if that makes sense, or exchange a little bit less privacy in exchange for more autonomy in the long run. So, I'm not a lawyer, and I haven't thought through, unintended consequences on this one, but I think that in general, what we find is that if we have systems that enable someone to have more of a life like they would want and still have enough surveillance, which, again, used appropriately would help them avoid more disastrous outcomes for themselves as well as for, people around them, I would think that should be among the things we would be able to offer somebody because especially, if you consider an under-resourced place where, like, maybe they can't do like a home stay, put on the actual hardware. But what if, you could use someone's phone to say, look, we're only going to use this to ensure that, you can leave your home, but you're limited from these kinds of locations. I think, it enables you to design a system which is more humanitarian, ultimately. Again, how you design it is critical, but I think it has the potential to design systems that help people avoid just that constellation of behaviors, whether it's people, places, things, the locations where you go to and you might get in trouble, the people you may get in trouble. If you can design systems that are maybe allow people to live the way they would want, but with some sort of trust but verify kind of data, sort of guardrails around that, I think that to me would seem like a system that would push things forward and not backwards.
Mm-hmm. I'd invite, jump in. Go ahead, jump in.
Yeah.
I'll invite those who want to. There's a mic there. We'll take your questions. I have one more question as you line up, but go ahead and answer this.
So for a slightly different view on that, so I think the way I think about this is that, I don't think that health and criminal justice are the exact same domain at all, right? I think within health, you might actually, even within health, you can have problems. But I think there's a perspective of we have all these resources at our hands. How can we make them work so that we can mitigate disease, we can mitigate the burden of disease, we can make sure that any number of things any number of good outcomes that you'd like to do. And then I think there's the more punitive aspect of things. How can we make our systems that are intended to penalize or check on people to kind of even work even better, right? And I think that a lot of times when we have these conversations, we just assume that the current state of things is fixed and how can we kind of make that better, but actually the introduction of algorithms changes the system, right? So if you now have these increased means of tracking every single behavior that everyone that one might have in their entire activity, then actually the set of requirements that we have for them is going to be even higher, right? That's just the reality of these things. So rather than saying, okay, you got to check in with your parole officer, however frequently it is that might happen, it might be, okay, you need to work this amount of time, and it might be much more fine-grained control. That's certainly going to be the direction in which you would be trending. And I think it's important to think about I guess a sense of entitlement that we have to different people's, how they choose to invest their time and how they choose to kind of live their lives, right? I think that we have a lot more scrutiny towards certain groups of people than others. I mean, is all of it deserved? Not super clear to me. I think sometimes it's actually not deserved, right? And so I think we need to think also about those unintended consequences. Mm-hmm. Yeah.
Just one more question, and before we open it up, Rediet, you mentioned the challenge of engaging with communities across a spectrum, and both of you mentioned just the need for massive amounts of data. How do we address in your separate spheres the challenge of data from marginalized, diverse populations? I'm thinking our center works a lot on dementia, and the move for biomarkers in dementia has been hampered in part by a lack of sufficient numbers of African Americans in the underlying studies, and the biomarker that you develop based on one sample may not be applied elsewhere. How do we address that? I think you both must address that issue somehow in your work.
Yeah, I mean, I guess my perspective on that would be, that's the sort of latent variable approach that I mentioned assumes that you're not going to get the same data from each person, right? So, and I would say that our general learning on this is that although it can break down based on cultural or disorder, groupings, it's really kind of orthogonal to that. I think we find that some people like to come in and provide their data with a human touch, so to speak. Other people might be totally fine, with a phone, and maybe that's how they prefer. Other people, they might use a different method. So I think if the concept here is that you can extract some key latent features from these people, but where you're intentionally designing a system that's going to be flexible to, whatever technical constraints you might be under, but also just the preferences of that individual in terms of what information they're willing to provide you. So,
Yeah, I mean, I think the first work that I mentioned was partially inspired by this problem that you're mentioning. So I think there's other sort of data sources like large web-based data sources that you could also kind of use to supplement. I think you have to be very careful about biases that those data sets also have, right? It's not a random sample of the population that you have online, and the way that they use it across platforms can be very different. So I think you can think about that. There's some data sources like that. I mean, this issue of like of kind of uneven data collection it's a problem not just among humans, right? So when I was at Cornell, there's this big lab of ornithology, and they had this huge problem where they have birders who go around and they collect data at specific places, and so they have a very good sense of like what kinds of birds are in that area, but then other areas they have no idea, right? And so they were in a sense like grappling with some thematically linked things, right, where they needed that data, they don't have it, and so they were designing these games essentially to incentivize people to go into areas they wouldn't normally go into to collect data so that you can have a better sense of, I guess, the bird populations across the United States. And so I think there's like a lot of lessons actually to be learned from many different domains about basically nudging responsible data collection in order to get a better sense of whatever population it is that you would like to assist. Yeah.
Great. Let's turn it over. I think there was a question here. We'll ask those who have questions to come to the microphone so we can hear them.
Hello. Thank you both for your talks.
And if you could introduce yourself as well.
I'm Lauren Chambers. I'm here with my colleague Miliano from the ACLU of Massachusetts, actually. And my question is for Dr. Baker. So a little bit of context. Miliano and I actually just yesterday had a hearing at the Massachusetts State House about a bill that's been introduced to put a moratorium on facial surveillance technology being used by the government. And I think that there are some corollaries here. So some of the concerns that we have about facial recognition technology is that as much as we might want to, bring this objective algorithm into our systems to reduce human bias in decision-making processes, the technology is not up to those standards. We had testimony after testimony yesterday from experts about how this kind of recognition works really well on white male faces and really not that well at all on darker-skinned faces and female faces. And that's one thing in the context of an academic setting, but it's another thing in the context of a courtroom where someone is being given, a sentence for how long they're going to be in prison. So anyway, my question for you is, how are you making sure that the things that you're measuring in order to make these sorts of diagnoses are free from different sorts of biases? So for instance, when you were talking about how you can map facial expressions and voices to different conditions, I was thinking about how women are socialized to smile more than men. And how African American vernacular English is a completely different dialect, and how that could lead to different vowel sounds. So how can we be sure that we're not going to be prescribing different medications to men or giving people more time in a hospital because they speak English a different way than white American?
Yeah, great question. So I think I think it sort of goes both ways, right? It's right now at a bird's eye view, what's happening is that because we don't have any objective measures, all sorts of people just don't give any care at all. And so part of what the rationale for developing these objective measures is to develop things that would be at least applicable across cultures, right? Now, you would still need to develop a data set, right, within a particular cultural context to anchor those features in the appropriate context. So as just part of any new system, you would need to develop it in a way that we're able to actually address some of those issues just by collecting more samples. I would also emphasize, though, that we're really focused on changes within a person over time. So it's less about the diagnosis, which I think we're often fixated on what's the diagnosis, but I think in mental health especially, the diagnosis may be of marginal value. It's really about detecting what someone's state is and then detecting how that state changes over time, where you're not saying it would replace, let's say, a clinical evaluation, but it's to say, like, all right, everything about this person's situation seems like they're doing as good as they ever get. Let's capture a snapshot what that looks like and then watch it over time as it changes, right? And so I think that's something where the empirical data will need to demonstrate it, but I think within subject changes over time, I think is one way to at least think about this. It's inherently going to adjust to that person's all the other individual factors that apply to that individual. I would say, in terms of how do you, in terms of thinking about these things so they don't get misused or they don't get kind of co-opted, I would say, yeah, there's absolutely no question that, we're not envisioning a future where you would only use these objective measures on their own, right? Because there's all sorts of unintended consequences if you begin to require, let's say, a smartphone-based phenotyping and you never have an in-person visit. That latent model I mentioned, it was like, it's all about detecting when you think there's a change, right? And then going to that individual and finding out if your theory is correct. So without that check to get the feedback about your model, these approaches would never work, right? And they might work, but they're very unlikely to work at scale. So I think, I can't speak to sort of, using facial expression in sort of like public spaces, but I do think that, in my opinion, and we could talk more about it, it would be vastly to people's advantage, patients, in care, to have some objective backstop with which they can sort of see their own treatments and conditions changing over time, especially just given the fractured nature of the care system of like, you're very unlikely to see the same person when you're young as when you're getting older. And so having the ability to design systems that would sort of be able to have your own data. Who owns those data? There's all sorts of interesting questions there. I think the individual ultimately should own those data, and it shouldn't be about, the government retaining these data sets. I think that's a separate issue. But, I will say, like, just one quick anecdote is, like, I had a patient the other day who was quite paranoid, and was worried about RFID and all the ways the government's tracking, facial expression, all these things. And he's consumed by these things. He thinks about them all the time, and it's really distressing for him. And I just asked him, like, okay, well, it's interesting, that this is so consuming for you. As part of the study, you're providing us with like 24/7 access to your location and all these other details about your life. Like, what makes you willing to do that? And his attitude was like, well, are you saying there's some reason I shouldn't trust you? And I think what we need to keep in mind from a healthcare standpoint is that the doctor-patient relationship is a special relationship where we routinely provide our clinicians with information we would never provide anyone else. And that's done because there's a value to that, right? This person probably would never be willing to do a study like this if the data were just kind of going to some clouds, So it's that relationship that he has with us that allows him to stay engaged in these kinds of studies. So I just bring that up as another, piece of this, of like, we do have different people or institutions in our society that are credentialed or allowed to kind of hold a certain role, hold certain information with a fiduciary responsibility. So we can't ignore all of that as we develop these systems.
Yeah, I would just, it's a great question to add that Justin and I and our colleague Benji Silverman are actively involved in addressing the ethics questions with NIH funding, and NIH is trying to do this in a lot of these new technologies so that you don't get to your technology deployment and then say, oh, we should think about the ethics, but that they're all the way along, and these questions are, and others are right at the course. A great question. Let's go to the next question.
Thanks so much.
And please identify yourself.
Sure. My name is Joseph Fridman. I work in the Interdisciplinary Affective Science Lab at Northeastern under Lisa Feldman-Barrett, who's the Chief Science Officer at CLBB. And I do some work with the Belfer Center, but I'm not speaking in that capacity right now. My question comes from a paper I recently read by a guy named Ian Hacking. He's a philosopher of science. The paper is called Making Up People. It's in the London Review of Books. But it's about these things called looping kinds. And the idea is that when we make a classification about people, we affect those people's understanding of themselves, and then we create new ways of being in the world. And so I'm really interested in digital phenotyping because it's an understanding of our behavior. Like the idea right from Dawkins is that you can look at all sorts of things that animals do in the world, and there's this extended phenotype, right? And so beavers build dams, and that's part of their phenotype, and you can look at how they built dams. But the idea that how humans use their phone is some part of their extended phenotype and can be used to diagnose them, and then humans can appreciate their relationship with technology and with the entire world as they're being tracked across the world as part of their diagnosis, and then part of their condition will fundamentally change the way that we approach psychiatric disorders, in the way that the introduction of multiple personality disorder as a distinction or autism as a distinction did. And I guess I'm wondering how we can track that and what work is being done. And I have a very practical question in addition to that is, do you collect this type of information about yourself and your lab members, and have you ever tried it? Thanks.
Great question. I mean, I could, so absolutely. I mean, I think for me, this idea that you could zoom out from someone's life and begin to see, based on places where they go and what kind of activities that they're doing, it's sort of like you can imagine the first time that humans left the surface of the earth and looked back down on it, of oh, that's the places I've been, navigating at ground level view for so long. Suddenly you see it from space, and you can see years of your life in granular detail, and how does that change, what you think about yourself and what conditions you might have. So I think that's certainly one of the things that I think is fascinating to me as humans are starting to do this for the first time. How will that change what we think about ourselves? The example that comes to mind for some, when before surgery was a discipline, back in the early 1400s, of before humans were, knew much about the human body. Vesalius, who was one of the first anatomists, he actually encouraged all of his students to go dig up bodies from the graveyard at night, because that was the only way to get access to the bodies, to the cadavers that they could then use to understand the human body. And that's why we have surgery today, is that while it was creepy and taboo and hadn't been done before, there was this cadre of people who decided it was worthwhile to nonetheless go and sort of see what it was all about and look inside the body for the first time. So, again, I think we're at this point where it seems a little strange to be able to see so much detail about what people's lives are actually like, both the kind of common behaviors that we all presumably do, as well as what we presume to be uncommon or, atypical. But I would say, until we've looked, we won't know what's typical and atypical, right? I mean, take any sort of construct of human behavior, whether it's very common or kind of on the fringe, I think until we've got systems that can look in unbiased ways, we're not going to have a map of human behavior that matches up with reality. So I think it's definitely a fascinating thing. And to answer your second question, I have phenotyped my own self, and while there's some ethics around I can't require anyone in the lab to do that, right? So there's all sorts of issues with human resources. If it's in your job description, you can do that. Otherwise, people are free to do it. We used to do it more in the early testing days, but now we have protocols where IRB protocols where people consent, as staff members, and can do it. But I found it fascinating. I would encourage anyone's interested, just to kind of see what your own life looks like in terms of how boring you kind of look, or how your routines and things like that. I think it does give some intuition.
I think I'll take my moderator prerogative to ask sort of a combination of the last two questions. We've just got a couple of minutes. So one is a question for you, Rediet, and then I've got a question for both of you. You described your interest in complex multidimensional spaces and trying to optimize across those. Wondering if you could just say a word about, as you go into domains where there is more dispute about what the agreed upon outcome should be, where do you see the role of algorithms in terms of optimizing? And that is, if we can't agree on what we want to optimize, is it more limited, or is there a way that you think actually intervening and these new perspectives will actually change even the normative discussion?
Yeah, it's a really good question. So I guess as a computer scientist, I tend to not, like I have, my own personal opinions about these things, but I tend to not like pick a side when there is some sort of dispute. But I actually see huge value in algorithms in this domain, because what happens is that, in my understanding about law is that sometimes ambiguity is actually a good thing, because you'd never get anyone to agree if it was like not ambiguous, right? That's sort of my understanding. But in my field, ambiguity is a bug, right? And so if you design an algorithm, it has to be very clear. It has to be very clear what the next steps are. The outcome should be the same. It's very cleanly defined, and it forces you to say, okay, I'm optimizing for X or I'm optimizing for Y, and you need to be able to write that down concretely. That's just how you have to do things, right? And what I found a lot of value in, so we have this work that is going to come out in maybe a couple of weeks that's basically looking at subsidy allocations, right, in order to minimize eviction, right? So what we've done is that there we had, a couple of different objectives that we were optimizing for. We have these algorithms and these results for each of those, but these objectives are optimizing for very different things. One of them is saying, I want to, minimize the sort of the highest chance that the worst off person is going to be evicted, and that the other one is saying, okay, I want to minimize the expected number of people that are being evicted, right? These are two entirely different criteria. I have my opinions about which one I prefer. Well, actually, my preference is that no one gets evicted, but okay, if you assume that there's like, a constraint on this budget, then okay, then you can have these two things, and these are going to do very different things. And in fact, they can do the exact opposite thing. They can be targeting people in exact reverse orders. So that's really helpful, right? Because then you can take that and bring that to people. Right now, you kind of say, okay, like this ambiguity that we had before where we said, we want to assist the most vulnerable individuals. No, you have to say exactly what you're trying to do here, because these results can be very different. And I think that can be a site where you can have these discussions, like actually forces you to have those discussions, because you're writing down what your trade-offs are. So I think there's a huge value there, the lack of ambiguity.
Great. So here's the last question, and I'm going to ask for super short answers, and maybe it's an unfair question, but I'd like you to reflect with us on timing. This is often what happens in these law and technology discussions. Is this stuff coming in 5 years, 50 years, a course of a lifetime? So maybe Rediet, we'll go with you first, and then Justin. When do you see a future where system designers, schools, hospitals, where it is the norm to use the sort of approaches that you're designing, or do you think that's already here?
Okay. I think it's here in some domains, and then it's very, very far in others. I think that my guess is that within the next 5 years, it will be reasonably embedded in every kind of big domain that we would think of. That's my guess.
Mm-hmm. And similar question, when are we going to be, if not the AI psychiatrist, but versions of what you're talking about as more regularly in the field of psychiatry?
Well, I have there's this William Gibson quote that I love mentioning here, which is that, the future is already here. It's just unevenly distributed. Which is to say, like, I would say people probably already are using these kinds of approaches now, but it's not necessarily common yet. And what I mean by that is, there are already clinicians experimenting with using tracking technologies with their patients, whether it's tracking sleep or step count or other things like that. And even you find, sort of medical, like hospital systems which are using, in some cases, like privacy-preserving cameras. So just like the depth component of a Kinect camera can capture shapes of things, but not as much information. You find systems like the Intermountain Hospital system out west, which they've started installing these privacy-preserving cameras all over the place at their hospital, not so much to track what patients are doing, but actually to track what staff are doing. So again, an ICU environment, being able to tell how quickly you were able to do the different procedures, or something as basic as hand washing, right? It costs hundreds of thousands, millions of dollars to these systems. they figured out that they could install these cameras and figure out and check to see whether the hand washing practices were changing. So those things are already being tried now. And I think as the technologies get a little bit better, whether it's the blockchain kind of privacy preserving aspects, or the technology, the cameras and things being cheaper, the phones, all our phones now having multiple ways of capturing these things, there's just more and more of an ecosystem that's allowing people to experiment. And I think we are going to, because so much cost is going to be saved, we're finding, I think, companies who are eager to capitalize on that.
Great. 3 quick things. Check out the website, join the newsletter, come talk to us. This has been great. Thanks to both.
Nice to meet you. Yeah.